Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about embryo transfer guidelines. So, what we want to discuss this day? The embryo transfer procedure, the protocol guideline for embryo transfer, transvaginal or laparoscopic transfer, which to use, how many embryos should be transferred, and lastly, how to do luteal phase support in short. Okay? So, about embryo transfer, the fertilized embryo are transferred at the cleavage stage 3 days after fertilization, or at the blastocyst stage 5 days after fertilization. So I have the choice either to transfer the embryo at the cleavage stage, which is 3 days after fertilization, or wait for 5 days after fertilization and do transfer for the blastocyst embryo. Okay? The blastocyst stage offer higher live births per cycle and is achieved with fewer embryo number and thus lower multiple gestation rate. However, what is the disadvantage? The downside of the blastocyst stage transfer is that fewer embryos may be available for transfer. Why? Because we may lose embryo that didn't survive in culture until day 5. So, until day 3, there is more number of embryo. Until day 5, there is less number of embryo available because they may not survive in culture until day 5. Okay? However, the success rate of the day 5 is better, and the number of embryo at this blastocyst stage day 5 after fertilization is less, and if we transfer less number, this is important to avoid multiple pregnancy and its complication. Okay, as you see in this picture, this is day 3 cleavage stage, and this is day 5 blastocyst embryo. Okay. Look to this picture, please. We do embryo transfer guided by abdominal ultrasound with partially filled bladder. As you see in the picture on the upper left side, this is ultrasound picture. This is the uterus, and this is the caster inside. It looks more echogenic here. Okay, we insert the caster up to 1 to 2 centimeter from the fundus. The best side at the upper and the middle part of the endometrial cavity. More than 1 centimeter from the fundus. Okay. Guided with ultrasound, the caster is inserted as in this picture. Okay. Then, after you did expulsion of the medium and the embryo inside the uterine cavity, please test the caster under the microscope to ensure there is no embryo retained in the caster, and that all embryos were successfully placed inside the uterus. Okay. What about the guideline? The protocol guideline for embryo transfer, according to the American Society of Reproductive Medicine, developed a standardized protocol for embryo transfer based on task force that evaluated survey responses regarding individual practices, amongst Society for Assisted Reproductive Technology medical directors. Okay. Starting with, one should prepare for the embryo transfer by reviewing period transfer notes. If the patient has an embryo transfer before and there is notes from the doctor doing this procedure in the past, please you should read these notes. Okay. Patient preparation for the procedure should include analgesic for patient comfort. However, analgesics are not shown to improve pregnancy outcomes. And there is also some studies about acupuncture in Chinese medicine, but also not proved to increase the pregnancy outcome. There is variation between women. Some may need analgesic, may not, but overall it doesn't increase the pregnancy outcome. Okay. Next, checklist based timeout process to ensure appropriate patient and embryo identification. Okay, as we mentioned before, transabdominal ultrasound guidance to visualize the endometrial cavity and the pelvic anatomy, as well as for ultrasound guidance of the transfer. Okay, so ultrasound, as you see in the picture, you can visualize the pelvis, you can see the uterus very well, and you can detect any pelvic lesion, any abnormalities, also guiding you through insertion of your catheter inside the uterus to put it in the proper place in the upper and the middle part of the endometrial cavity, as I mentioned, okay, before. So ultrasound is important. Okay, what about sterility condition? Standard sterility preparation with hand washing and use sterile gloves. That's it. Okay, placement of the speculum, flushing of the vagina using cotton or gauze, utilizing a saline. Either you use saline or use the media as a cleansing solution. Okay, please don't use antiseptic or broad spectrum antiseptic or something like that. Please don't use it. Use either the media or saline as a cleansing solution. Okay, so you can remove the mucus from the cervical canal with some evidence for improvement in clinical pregnancy rate. Okay. Use soft embryo transfer catheter to pass through the cervix into the endometrial cavity. As you see in this picture, this is an example of some embryo transfer catheter, okay, with two outer catheter and the inner catheter. And this catheter, as you see, it was proved that soft embryo transfer catheter is better than hard one, and the pregnancy outcome is more successful. Pregnancy outcome is more with soft catheter. Okay, this is as regard the guidelines. Okay, either you use the catheter filled before placement, or you insert the outer catheter, remove the inner catheter, then load the inner catheter with the embryo, then insert it inside the outer catheter in the proper place inside the endometrial cavity, the upper part of the uterus and the middle part, at least more than 1 centimeter from the fundus. This place, as I said, in the upper or middle third of the endometrial cavity has improved the pregnancy rate. Okay, one should confirm the caster doesn't have retained the embryo by looking under the microscope after doing embryo transfer and extraction of the caster. Please immediately look under the microscope to be sure that there is no retained embryo inside the caster. Okay, there is no evidence for bed rest after embryo transfer. Some advise just to lie in bed for 1 hour, then go home. Okay, that's it. Okay, but there is no evidence for bed rest after embryo transfer as regard increasing the pregnancy, the successful pregnancy outcome. Okay. Okay, using the transvaginal or laparoscopic, as we mentioned before, we are using transvaginal method for transfer of the embryo through inside the uterine cavity by using caster passing through the cervix. This is the majority, of course. But what if we have congenital anomalies or obstacles or something obstructing, mechanical obstruction inside the cervix due to anomaly or organic lesion or whatever? So we are in need for laparoscopic transfer, okay, via gamete intrafallopian transfer or zygote intrafallopian transfer as an alternative laparoscopic transfer technique. Otherwise, everything is it's okay anatomically, transvaginal, of course, constitute the vast majority of embryo transfer. How many embryo? This is a very important question. Single embryo transfer in patient with a favorable prognosis. Single embryo transfer. Why are you afraid from multiple embryo transfer? Because we are afraid from multiple pregnancy and its complication. Okay, so we are trying to reduce the number of transferred embryo to increase successful pregnancy outcome at the end of pregnancy. Okay, so single embryo transfer in patient with favorable prognosis. What is this category of women with favorable prognosis? If you transfer euploid embryo is the normal after you doing pre-implantation genetic test. Okay, if you did pre-implantation genetic testing and this is euploid embryo, okay, transfer only one embryo regardless of the patient age as recommended by the guidelines. Okay, if the patient is below 35, should be strongly encouraged to receive a single embryo also transfer regardless of the embryo stage, 3 or 5. Okay, after fertilization. For patients between 35 and 37 years of age, strong consideration should be made for single embryo transfer. So for all these criteria, single embryo transfer, either age below 35 or between 35 and 37, or I did pre-implantation genetic testing and it was found to be normal euploid embryo, so single embryo will be transferred and this is enough. Okay, but you can consider 2 Blastocyst embryo transfer if the patient age between 38 to 40, and you can consider 3 Blastocyst embryo transfer if the patient aged 41 to 42. Okay, okay. But in women 43 years or more, as regard the guidelines, there are insufficient data to recommend a limit on the number of embryos to transfer when the patient uses her own oocyte. And the cautions should be exercised as the risk associated with multiple pregnancy increased dramatically with advancing maternal age. Okay, so if multiple pregnancy happened in age 43 and above, the complication is more. Is there any luteal phase support after you did embryo transfer? Yes, immediately start progesterone support, either suppository or injection, intramuscular, okay, and estrogen supplementation to promote implantation and the pregnancy continuation. This is the end of my lecture. Thank you. Please remember my 4 books published on Amazon: textbook of obstetrics, textbook of gynecology, contraception handbook, and the last one, multiple choice question in gynae and obstetric and contraception. And this is the link on my site on Amazon as a author. Thank you.